Hello everyone, my name is Leslie Cornwell, certified nurse midwife and CEO of Midwifery Business Consultation. The topic I want to talk to today is implementing team-based care. ACOG had a great 60-page document about implementing team-based care. It's been used in numerous specialties, not just obstetrics, but I thought with being a nurse midwife and a lot of midwives have to work on collaboration, and especially if you're a hospital-based midwife, implementing team-based care will be a very valuable tool for it. So the objectives of this course is to be able to explain core principles of team-based care, better understand patient rights and the meaning of shared decision making, be able to fully understand why team-based care is so important in today's ever-changing healthcare system, provide tools for creating team-based care into your organization, able to understand barriers present for team-based care. There's no conflict of interest in presenting this topic. So team-based care's purpose is to improve the quality of the care, make it more efficient, and provide more value that are necessary characteristics of an ever-changing healthcare system. It's reinforcing that the patient is at the center of all the decision making and that one healthcare provider or part of the team doesn't have more expertise or opinions of the final decision. So the physician wouldn't necessarily be the one to make the final decision over the nurse midwife, the nurse, the pharmacist, the social worker. They would all work as a team with the patient to make the best decision for that person's individual needs. It's a lot working towards the triple aim, improving the experience of the care of the patient and their families, improving the health of our population, and lowering the capital cost for each individual. As insurance companies and healthcare gets more and more complicated in the United States, we have the most expensive healthcare system around the world. So when we're spending more, you would assume we'd have better outcomes, but that's not actually the case. So what can we do to redirect our focus and make our outcomes better for a better price? Team-based care purpose, respond to emerging demands of reducing the undue burdens of the healthcare providers. As a healthcare provider, there's more and more burnout, there's more and more demands. The insurance company reimbursement rate, it's expecting you to see more and more patients with less time, more documentation to protect your license, more charting and compliance and checklist and meaningful use. And there's a lot of pressures on the healthcare provider to give good outcomes. The ability to be more efficient, meeting the core expectations of a healthcare system proposed by the Institute of Medicine. Team-based care expectations require that our care to be safe, efficient, effective, patient care centered, timely, equitable. We want to create value. If we are charging $300 for their new patient office visit, we expect to give $300 worth of value to that patient, whether it's education, whether it's treatment options, whether it's an assessment to know that they're healthy or there's concerns present, but we have to be respectful of the person. It's a lost art in the United States as far as healthcare was created to serve families and to help make them well and healthy. And it seems to be a little lost with focusing so much on the charting and the expectations to see people in health insurance reimbursement that the patient gets lost in the mix of all that busy hustle and bustle. Team-based expectations intended to appeal to specialties. It can be used in any specialty. I'm mostly going to talk about women's healthcare obstetrics team-based care just because of my background. Any profession can apply this. A nurse practitioner, a nurse midwife, a physician's assistant, any physician specialty, pharmacist, advanced practice nurses, and I've seen great social worker nurses implement team-based care. Our goal is to get together a group, look at this patient's history, look at this patient's needs. It'd be great to have the patient at that conference meeting if we can, to get their perspective of what their goals are. We could have the greatest decision under the sun, but if that doesn't work for the patient, it doesn't matter. So team-based care organization has a strong team-based focus for the public health centers offering more comprehensive and coordinated care. It's shifting a culture so that we are all on the same page. The physician doesn't know any more than the nurse does. We all have a different perspective to take care of this patient. We're going to build respect and trust within the team. We're going to sense a collective responsibility to the health of this patient. We all want what's best for the patient, and we're all going to have a different aspect of taking care of that patient and keeping the patient at the center of all this. One recommendation may say to do it one way, but there may be different recommendations from each person's educational background, but also the patient. The patient may have different cultural background, not wishing what's currently being recommended. So we have to think of all aspects. It's a team taking care of these patients, including the patient. So team-based care, what is it? Care of an individual by at least 2 healthcare providers who work collaboratively to take care of the patient and their families. So I'm going to stress over and over again, patient-centered and collaboratively working together. We are a team. I know sometimes, especially with a private practice and a nurse midwife, there are challenges of you get into the healthcare system and that collaboration is sometimes lost. And so you want to make sure we're equals. We each have our own knowledge, expertise to work from to help give suggestions of what's best for the patient at this point in time. Accomplish shared goals. What is our purpose? Why are we here to take care of this patient? What's their diagnosis? What's their treatment options? What is our end result? Is it hospice care? Is it getting a normal, healthy baby within the birth preferences this mother has in place? What is our ultimate goal? Strive to meet the patient's needs by actively engaging the patient, doing hospital huddles, doing transfers where the family is actively involved in that phone call to the provider, going into triage and having the nurse, the physician, the midwife, and the patient all making a decision of why we're here, what is our goals, and what do we currently suggest as a way to make it happen. Encouraging all healthcare providers to function within their knowledge and expertise. So not limiting one person's scope just because of bylaws or outdated standards, letting each healthcare professional work within the full extent of their education and experience really helps out team-based care. Team-based care, the point of it is to have seamless communication. You don't want to have tension and frustration between your healthcare providers. You want to be able to be professional, have a collaboration where each other is being respected, especially during shift changes, huddles, the delivery happened, an unexpected event with a C-section. You want to be able to respectfully debrief and have the patient involved in that. Evolution away from a single provider team to a team-based focus. So look at your organizational values, look at your patient's values, have your patient every step of the way involved in the decision making. ACOG's positions on patients' rights, I thought it would be a good idea to just go back to the basics. Why do we do healthcare? What is our focus? How do we respect each other and our patients? Pregnancy is not an exception to the principle that a decision capable of a patient in their right mind, they're not having dementia, they're not in an altered state. You may argue during labor and transitioning and pushing, but they can still think for themselves. They have the right to refuse treatment once they've been given good informed consent. Women's decision to refuse a recommended treatment or intervention should be respected as long as all the risk and benefits have been given to that mother and family and given them time to have a discussion. Obviously, if there is an emergency happening, it's totally different, but most of the time we can have a good, honest conversation with the entire team present, not just the midwife going in the room, not just the physician going in the room. The nurse, the physician, the midwife are having a group discussion with the patient and her support team of what are her options. No use of coercion. It's not ethical to push somebody to do something that you feel is best for them based on your fear, based on your personal biases, based on it being 10 o'clock at night and you're tired. So we have to be careful as healthcare providers, and that's the nice thing with doing a team approached care, is each person's personal biases get a little more muddied versus one person goes in the room and talks to the patient. never acceptable for obstetricians to attempt to influence their patient's clinical decision using coercion. And I see that more and more often, and it breaks my heart with pediatricians. I've seen it with midwives, obstetricians, where the personal decision making or personal schedule and wants get pushed through of what they think is best for this patient. Discouraged in the strongest possible terms to not use manipulation, physical force, threats to get a woman or her support team to do a specific clinical decision making. It is very difficult when we have, on our perspective, clear indications for a C-section or for an induction or XYZ, and the patient is given informed consent, and based on their cultural wishes, their preferences at the time, they're declining, and we have to respect them for that. So it's important for obstetricians, midwives, care providers to resolve their differences in a team approach care. It helps you recognize that personalized patient's context. We're trying to understand what this woman needs in this situation, not what our book says is the best recommendations. And sometimes you have to have an ethics consultant. Sometimes you have to get the hospitalist involved and have a different perspective looking at the situation. But try any way possible to use coercion to get a pregnant woman to do what we want or we think that they should. ACNM, the nurse midwife's position on shared decision-making partnership in which the woman and the provider share information values that are best decisions regarding a plan. Foundationally, integral part is patient-centered midwifery care and evidence-based quality. We want to collaborate with the woman and the family, and I think we need to add the entire healthcare team to promote what's best safe outcome for this specific situation. Effective communication is central to shared decision making among our collaborating physicians, our nursing team, our birth assistant, and our families. We need to be able to clearly and respectfully discuss our concerns and our options available to the families. ACNM also has further position statement of midwives share an anticipatory guidance of an open, objective, culturally sensitive manner to the mother and the family. Recognize that the woman is the final primary decision maker for herself and her baby. She's going to pick what she believes is best, and we need to respect them as long as an informed care is made. That's why team-based care is so helpful, because we're getting the perspective of the obstetrician, the family practice doctor, the pediatrician, the midwife, the nurse, all on the same page with the patient. I've seen it so many times where the midwife comes, has a great discussion with the patient, and then a half hour later the doctor comes in and has a totally different discussion, and it makes it hard for the patient to feel confident that her whole care team is on the same page. Women maintain the right to informed refusal of recommended plans of care based on her personal decision making. Coercion and abandonment of patients is not ethical. Collaborative practice. So I stress over and over again, collaborating, working as a team, mutually beneficial active participation between autonomous individuals. Team-based care requires more than collaboration. Each person has knowledge and skills that will be helpful to contribute to the best outcome for this patient, the mother, and their baby. So team-based care has meaningful engagement. It's established by having professional collaboration. We respect each other for our experiences. We build a respectful relationship, and time is not rushing any of these decision making. Does every person need a team? Yes. It doesn't even matter if it's something simple. She's having a low-risk healthy pregnancy. She's 36 weeks. Nothing has happened. It's not a bad idea to have other people brainstorm. I did it in my office all the time. I talked to my receptionist. I would talk, how can I make this better for this person? What other things can I suggest? We've been doing our routine education, and sometimes even ask the patient, like, what else are your concerns, your wishes? What did you read about? What are things I can personalize this to make a better outcome for you and your family? Enhancing the communication and connectivity among the team makes it more fluid and transparent. So when the patient is in a more vulnerable position, like like during labor, there is an easier conversation versus there's not that relationship. There's a lot of tension present. It's harder to have that team-based communication. Integrated care processes are over a course, not just a specific event. And I think we talked about that. The midwives have an advantage versus a labor and delivery nurse that we've seen them the entire pregnancy and built a relationship. Reducing overuse and unnecessary testing, I think in obstetrics especially, part of why our healthcare system is so expensive is the overutilization of intervention leads into intervention. Many women are low risk and healthy and should be treated low risk and healthy. High risk equipment, I'm very grateful we have, but they should be used for high risk patients. Improve patients' experience. When you personalize it, when the woman is in charge with her care provider, you get a lot happier outcomes, short-term and long-term. I stress that to midwives and over and over and over again, this woman, even though you've caught 1,000 babies, she will remember this the rest of her life. So treat it like this is your first and only birth you will ever see, because to her it may be that. Guiding principles. Patient and families are centered to, and the active engagement of the family, the members of the team. There's shared vision. The role clarity is essential. I'm here and I'm going to do this for you. I'm your nurse midwife. I am the one going to take care of things. If there's some concerns outside my scope, this is the amazing obstetrician that I work with throughout the night. They're in-house just in case, but I don't anticipate we'll have any of those concerns or conversations. This is your nurse that's on tonight. She can help with any of the things if I'm not available. This is what each person's role is, to take care of you, and making sure each person is accountable for their own practice and what they've been delegated to. So in the situation can always change, because if you plan on her having a normal healthy birth but all of a sudden the baby gets stressed out, those roles are going to shift quite quickly. But when you make it at the beginning anticipatory that the patient knows each person's responsibility, they won't be so surprised when the OB stops in and says hello because, oh, something's going on, because at the beginning of the shift the midwife said that I would see this person if there was concerns. Patients actively engage. Care should always be patient-centered. We assume that, but it kind of gets taken for granted as we get busy. And I mean, sometimes it's not patient-centered. It's about what's best for that physician, because they've got so many people lined up, or even the midwife. They've got a lot of births. They've got a lot of triage patients. They've got office waiting. It a lot of times shifts to what's best for the provider at the moment versus the patient. So we really need to get back to the basics of focusing on the patient's values, preferences, and goals, and respecting them. Spending enough time to get that personal relationship and see the patient as a partner in the team, not that the physician or the midwife knows best, but the patient should be actively engaging in the decision making. You are the expert in the medical, they're the expert in them. Patient-centeredness as valued as clinical outcomes, accomplished by establishing a shared, clearly articulated goal. So it's nice to have a whiteboard in the hospital room that you can put. When we have the advantage of being a home birth practice, it gives a lot of that power and autonomy to the patients. We're guests in their home. So that patient-centered is very known because we're in their space. Some of that patient-centered autonomy gets taken away when it's a hospital setting, even in a birth center, because this is our space, this is our medical facility, this is our quote-unquote home away from home. So we have to respect those dynamics present. So mutually decided on a patient in the healthcare team, we always have to put the patient first. You will hear me say that about 20 more times. Elements of a successful patient engagement. It's establishing a common vision, creating a culture of engagement, employing the right technology. It's amazing to have an electronic health system, but if we lose patient-centeredness with an electronic health system, which I see very often, where we're asking questions, not ever looking at the patient anymore, just filling in the clicks in the questionnaire, we're losing the art of midwifery and losing the art of taking care of patients. Empowering our patients, giving them choices, asking them what's going on with them, allowing them little simple autonomy of respect really goes a long way. be ready to evolve and to adapt. Like you may have a plan at the beginning of the shift, and maybe the patient wants something different. Maybe there's some interventions needed because you didn't anticipate XYZ. So we have to in healthcare be adaptable for the needs that are needed of us. Effective communication in all parts of the team. You're going to hear over and over again: collaboration, patient-centered, effective communication, respect. These are the cores of any workplace, but they're especially important with health. So role clarity, making sure that everybody is recognizing their expertise, their skills, and being comfortable saying, I've never done that before. I've had a couple situations where an obstetrician worked with a few midwives that did first assist or did certain aspects of services, and maybe another midwife doesn't do it. And just having honest conversations of, well, this is my skill set, this is what I do, and do you want to have more training on it? But in the moment, you just know each other's skills and you utilize. You maximize each other's expertise for the team. If you have a maternal fetal medicine doctor, it doesn't make sense to have them do low-risk healthy women. Mayo Clinic has been doing a great job that midwives take care of the normal, low-risk healthy. They have a conversation, work as a group with an obstetrician. If something comes up and if they become really high risk and sick, then we'll work as a team to get maternal fetal medicine involved. Critical to have mutually defined roles and responsibilities. If things aren't written clearly of what each person's supposed to do, you get assumptions, you get breakdowns in communication, you get barriers, and that creates gaps in care. And the patients are smart and they see that. So this is a great way to look at provider involvement. So typically, I know we talked about a little bit, prenatally, a nurse midwife takes care of them, and maybe we need to get MFM involved a little bit. The patient has pre-diabetes, but then they start getting better, they get worse. Like the plan constantly fluctuates, and then towards delivery time, oh, they're starting to get better in their care. The nurse midwife can take care of them for the birth, but oh, it's starting to get a little worse. Now we have to deliver at the hospital. We have to work with an obstetrician MFM. Like, you have to look at the individualized needs. Maybe you have to see them more often. Maybe the midwife sees them and then MFM or an obstetrician sees them. There's a lot of things you have to individualize based on this patient's needs. Accountability. Being able to respect each other means that you have to, based on your scope as a midwife, obstetrician, nurse, be able to practice within your ability, consistently thinking about what's best for the patient, the cost, the quality of the care, the timely delivery. If it's going to take 2 months to see MFM, but the obstetrician across the street can see him next week, you really have to look at makes the most sense for the patient's needs at this. Accept only responsibilities that you're willing to do. If the obstetrician said, hey, this is your first night on working as a nurse midwife, I need some help with first assisting. If you've never first assisted a C-section before, you need to say it. You need to be respected and make clear expectation of what your scope and skills are. There's sometimes tension because people make assumptions that one person can do this, so that means that all professionals within that scope can do it. So you need to have clear expectations, not just based on your experience, but your advanced skills, what each person on the team can do, and respect each other for it. Maintain education, keeping up with your license, keeping up with your continuing education, drills, debriefings, literature, attending chart reviews. Those are all really important things for all care providers, and it builds trust among the team. So that's one of the best ways to build trust with your patients, your colleagues, is to work closely together to improve that accountability. Research or evidence to support that additional. Can you clarify it to me? So our goal is to give cost-effective care, improving the outcomes, and doing what's best for our patients. Effective communication, keys to quality teams. Be able to relay important information that's task related, provide evidence, provide specific improvement processes in a respectful way. I've been in a lot of work environments where it's great, it's amazing, but then I've been in ones where it's not. If there's hostile work environments, it's really difficult for a midwife to comfortably present a case or a situation to a physician and a nurse to be able to talk to a midwife, if you have this very clear hierarchy present, it is difficult to have mutual respect among each other versus as a team-based care, everybody is here, everybody has different skill sets that can add value to the patient's experience. Effective communication, create culture that enables continuous learning among all the team players together. Optimizing communication requires trust, honesty, transparency, and timeliness. And so I always add these little comic strips in here, but sometimes little things we think are so silly, if you're not counting at the same time, do you really want to drop a patient on the floor? Like, we need to all do it together. We need to count 1, 2, 3 as a team, not just the physician saying it and then everybody makes assumptions what they were referencing. We joke about it, but it can end up in serious mistakes by having this hierarchy where the nurse doesn't feel comfortable to ask for clarification. Team leadership can be situational and dynamic. The midwife might be in charge, the nurse might be in charge, the pharmacist might be in charge for a while, the anesthesiologist might be in charge for a little bit if they're getting an epidural. Sometimes during the C-section, there's a lot of tension between the obstetrician and the anesthesiologist. That's quote unquote who's in charge. And I think it changes all the time and we need to respect that. If they're doing an airway and they're doing the epidural and they're doing the direct anesthesia, there's a higher priority of the discussion of the needs from the anesthesiologist's perspective. But if we're in the middle of a C-section or a normal vaginal delivery, a mother came in, wants an epidural, anesthesia's in the room, but she's going to have a baby without it, you got to feel comfortable and respected as a midwife to say to anesthesiologist, okay, I'm the team lead right now and this is what we need, and have each other's respect for it. So shared power, collaboratively work together for what's best for the patient, not focusing on who's in charge. No, this is my patient. No, this is my patient. I would hear that so many times in discussions and debriefings later when it's all of our patient and the patient is part of that decision making on the team. We should encourage the patient to be actively part of that decision making. Like, I would love to see debriefings where the patient is more involved than just the staff members when we talk about it and ways to improve. Implementation of team-based care. It's essential to first assess the needs of the population you serve. Do you have a low-risk, healthy home birth practice, or do you have a high-risk obstetrics facility? Do you have midwives? Do you have obstetricians? Do you have maternal fetal medicine? Are there in-house anesthesiologists? Is it LDRP? Like, look at your population you serve as patients and the layout of the facility that this service is being provided in. Team-based care approach is being able to practice fully to your extent. It's very difficult if you have a national scope and training, a state level, and then you have a hospital privileges that's more restrictive. It's very difficult that, oh, I worked for this hospital across the street, now I work for you, but I can't actually do X, Y, Z. It's difficult for midwives to really be able to practice when there's restrictive bylaws in place that affect the autonomy. Seeking to practice with interprofessional relationships. So the more you can attend meetings together, the more you can learn and understand each other's practice, licensure will improve the outcomes for patients. All OBs are encouraged to provide care that's culturally specific, modern care, shared decision making, doing a C-section when necessary, not making it elective, not making it a routine practice, and VBAC is safe. I know there's a lot of fear around litigation and the stats involving VBAC and uterine rupture, but we have to give honest, unbiased options to women based on her choices. Minimal interventions does maximize satisfaction. Most women are normal and healthy. Not doing an episiotomy, not inducing unless there's a medical reason, not augmenting unless there's a concern. When we rupture the water, we do an epidural, we push and pressure women on a time clock. It makes it a lot harder for the outcomes to improve. Opportunities for implementation. Costs and payments tied to quality. Currently, insurance companies pay based on time. There's a flat rate you get for maternity care, whether you stay with them and do a lot of prenatal visits, the minimum amount of prenatal visits, you spend 5 minutes, you spend an hour. Birth is the same way. It's paced, whether you miss the birth, you still get the placenta delivered, you get the same rate versus you do one-on-one labor support from admission to discharge. So that's what makes it hard. Sometimes there's a little bit of a financial incentive to do a C-section because of the time. You do a 45-minute scheduled C-section, you make more than if you are co-managing your office and this woman for 3 days in an induction. So we really need to get it based on high quality, positive outcomes, positive patient experiences, decreasing nosocomial infections, decreasing C-sections unnecessarily will improve the outcomes when there's cost involved in that. The practice functionality, like if you're utilizing only pieces and parts of a person's scope on your team, you're not improving the outcomes, you're not improving the best quality for the entire team that the patient is now suffering. Opportunities for implementation, workflow, navigating the scope, the revenue. It's difficult for a healthcare provider. You have to do it as a team with your organization, your office manager, your biller, your managers of inpatient labor and delivery, your birth center. It's not just the healthcare providers fixing and improving these systems. Communication, I stressed it over and over again, being respectful of each other, understanding each other's skills, making the patient the most important focus of the team will make a lot of these outcomes better. Partnering with the patient, most underappreciated challenge facing practices seeking to collaborate is designing an operational system that's built on the firm commitment to partner with the patient. Partnering with the patient is engaging them, and the challenges can be overcome in a number of ways. Educating the team on the benefits of the patient helping with the decision making, using reliable, high quality decision aids, facilitating patients' participation. So having those bedside huddles, having during the office visits, not just the providers having side conversations. Like I would call my specialist, my collaborating obstetrician on speaker in front of the patient so we could all have a discussion together and I don't have to repeat. And it made a difference. That obstetrician I talked to did speak differently to me when the conversations were on speaker. I let them know ahead of time, hey, I have you on speaker with the patient. This is what's going on. This is our thoughts as a team. What are your thoughts? It will help. So other parts of implementing the tools for change has to do with overcoming those enormous challenges. Change is difficult for healthcare systems, for nurses, for providers. We have to get back to the basics of what is best for a patient. Everybody has the knowledge and skills to make this a better outcome. So here's my conclusion. I appreciate everybody listening for the last 30 minutes, but team-based care, it may seem simple, it may seem obvious, but it's a lost art that needs to come back. We need to respect everybody for their skill sets. One person does not have a higher power of decision-making over another. We all have different perspectives. The patient needs to be the focus. We need to communicate with our nursing staff. We need to communicate with our physicians, our midwife colleagues, our specialists. We need to be responsive to our hospital staff. If we get paged because they need to get a clarification, we need to respect that in the best of the time. Pain management, it's harder with birth, but pain management doesn't mean making it go away. It means we gave comfort measures, we did hydrotherapy, we did one-on-one labor support. We met the needs that the mother wanted from us. That's why having a good discussion about birth preferences before labor is really helpful. Knowing I want an epidural, I want nitrous oxide, I want a water birth, I want to be able to actively move freely versus sitting in bed. Like, these are really important discussions to have that'll improve your satisfaction and your outcomes. How clean your environment is, like our housekeepers, our lab, our dietitians, like these ancillary services are just as important as the frontline patient care staff. So yeah, if there is stuff on the floor, things are dusty and dirty, that affects your patient satisfaction. Discharge instructions, there's a lot of information information that happens in a short amount of time. Make sure it gets in written, make sure there's an easy place that the patient can call later to clarify things. So just overall, hospital ratings are really affected by these 8 core things. And it all comes down to team-based approach, patient-centered. Implementation can be hard, but the long-term benefits will really improve those short-term difficulties. Here's some examples of important communication. I always try to do a little bit of humor. Here's a short video if you'd like to watch a longer video about how breakdowns of communication can be good and bad. Here's all my references if you have any questions, and I look forward to you implementing this into your private practice, implementing it into your collaboration with an obstetrician, a pediatrician. If you're a midwife in the hospital, there's a lot of great ways to use this team-based care.